So I'd like to move on and discuss procedures for stroke prevention. And so we basically have two procedures available to us for carotid artery stenosis. One is endarterectomy, which has been around for a long, long time, and then carotid artery stenting. The Crest trial, which compared the two in both symptomatic and asymptomatic carotid stenosis, was published in 2010. I want you to focus on this middle panel. So what this is looking at is the comparison of the two related to the age of the patient. And overall, the trial did not show any significant difference in secondary stroke prevention in the patients that were included in the trial. But what you see here is that in younger patients, up to about 55 or so, stenting seems to be superior. And then between 60 and 70, no real difference. And then as we start to get a little older than 70, endarterectomy has a better effect in reducing recurrent stroke. So in younger patients, we might think about stenting more, and in older patients, endarterectomy. And those between 60 and 70, you can choose either one. Recently, the 10-year follow-up data for Crest were published in the New England Journal, because the first study, I think, was only out to about 4 years. And basically what the 10-year data showed us is that for the primary endpoint, really no difference over time between the two procedures. They both were equally effective in preventing a recurrent episode. And so here what they did was they looked at the follow-up over time, in a little bit closer look than the previous slide, because this is drilled down a bit. There is some suggestion at some points that, earlier points, that stenting had more recurrent events than endarterectomy as far as stroke or death. But then when you factored in MI in this, which is one of the outcomes, there were more MIs in the endarterectomy group. But most of the MIs were not significant MIs. They were just an increase in cardiac enzymes as opposed to significant damage to the myocardium. There was a recent study that was published earlier this year, which randomized patients to stenting versus endarterectomy with asymptomatic carotid stenosis up until the age of 80. And so I'm going to show you the results of that now. This was done in the US, and it was a 3-to-1 randomization of stenting versus endarterectomy. Patient populations are compared, and they're highly comparable in the trial. And what you can see from the Kaplan-Meier curve is no significant difference in all stroke over the 5-year follow-up of the trial. So basically, in asymptomatic carotid stenosis in patients under the age of 80, you could choose either one of the two. But the real question is, does aggressive medical therapy actually reduce the risk of stroke in patients with asymptomatic carotid stenosis using modern medical management, which would be aggressive treatment of risk factors such as hypercholesterolemia, hypertension, diabetes, et cetera, diet. And so there's a second Crest trial that's ongoing now called Crest 2, and it has 2 different components. So in one part of the Crest 2 trial, patients are randomized to stenting versus best medical management. And then the other part of the trial, it's endarterectomy versus best medical management. Because we really don't know at this point whether a procedure needs to be done in these asymptomatic patients. And so it's going to take a while before we have the results of those. And I would advise everybody to keep an eye on things. It's probably going to be at least 3 or 4 years before, maybe even longer before we know anything. And I think there's a European trial that's also looking at this question as well. I want to very briefly mention another study which was published in the New England Journal this year, which compared pioglitazone after stroke or TIA to best medical management for preventing recurrent strokes in patients with insulin resistance. And so it included patients over the age of 40 with a stroke or TIA and who had insulin resistance defined by a HOMA measurement of the insulin resistant index. The primary outcome of the trial was ischemic stroke and MI, and then there were lots of secondaries. And basically, this table is right from the New England Journal paper. There was a significant reduction with pioglitazone compared to placebo of stroke or myocardial infarction. It was significant for the combined endpoint, but for the secondary endpoint, there was a trend for both, and that's because the number of outcome events is obviously lower than when you combine them together, and so that's why those did not reach statistical significance. However, there are some concerns about pioglitazone. There was a significant increase in the incidence of bone fracture requiring appropriate treatment in the pioglitazone group. There was also a significant increase in the risk of substantial weight gain. So the benefits may actually be outweighed or balanced off by the side effects. And at least in the US, I don't know of many physicians at this point that are actually recommending pioglitazone to their patients. It's also not so easy to do the insulin resistance measurement that was used in the trial, and it's not widely available. So I think those are both problems with trying to adapt the results of this trial to clinical practice. So I'll skip this because I've already covered it. And then I just want to mention something else on the last 2 slides. This has been a concern of mine for a number of years. And we see this very commonly where I live in Massachusetts, that patients with atrial fibrillation are very commonly placed on aspirin or another antiplatelet drug in addition to being anticoagulated. And we did a survey at the hospital I used to be at, UMass, a couple of years ago, and over 40% of the patients in our anticoagulation clinic who were on warfarin, primarily at that point, were also on an antiplatelet drug. And what we know is that if you are on both of these drugs, the risk of intracerebral hemorrhage as compared to being on warfarin alone is approximately twice as high. And most of these patients, so here's an interesting slide I took out of a paper from Denmark a couple of years ago. So if our sort of reference is warfarin alone, the risk of serious bleeding side effects with aspirin alone is a little bit less. Clopidogrel alone is about the same. Aspirin plus clopidogrel, significant increased risk as compared to warfarin. Warfarin plus aspirin, the hazard ratio is almost twice as warfarin alone, warfarin plus clopidogrel 3 times, and then some patients are on triple therapy after they've had a coronary stent and they have AFib, and they're on aspirin, warfarin, and clopidogrel, and you see the risk is really, really high. So I would recommend that you pay close attention to the patients you see who are on warfarin. Many of them are on an antiplatelet, aspirin, and a lot of them don't need to be on it. So we commonly recommend to our cardiology and internal medicine colleagues to stop the aspirin unless there's a really good indication, and just leave them on warfarin alone. And one thing that the internal medicine community seems to have forgotten is that in patients with coronary artery disease who are not stented, that there's a lot of old literature to suggest that warfarin is equally as effective in preventing MI as aspirin. So if you have an AFib patient and you're trying to prevent stroke, and they also have ischemic coronary artery disease without a stent, warfarin alone should be sufficient. So pay attention to this and try to make your colleagues aware of the fact that using anticoagulation plus antiplatelets is a risky situation. It appears to be just as risky for the new drugs as it is for warfarin and antiplatelet drugs. So I think it's reasonable to try to avoid the risk if at all possible. So I'm going to end there, and I thank everybody for their attention.